Hi, I'm Dr. Jeff Rockwell, and I'd like to welcome you to our three-part video series on chiropractic myofascial release. Before we begin actually showing technique, I want to go through a brief introduction about the technique and what you can hope to accomplish through it and why we can hope to accomplish those results. Obviously, from the title, we're going to be releasing myofascial tissue, soft tissue problems in the human body. But the operative word in that name, chiropractic myofascial release, as far as I'm concerned, is chiropractic. Now, whether you're a chiropractor or a PT or you're a massage therapist, it's important to understand that what we're doing here is taking a chiropractic or a biomechanical approach to soft tissue problems. Much of what's been taught as myofascial therapy for the probably past 50 or 60 years has been rather allopathic in its approach, locating a source of pain and then chasing the pain around the body. Now, we're going to learn how to treat pain syndromes, but at the same time recognizing that probably the most common source of pain is postural distortion. We're going to be seeking to correct both human structure and human function. The definition I like to give for chiropractic myofascial release is this: it's the science of restoring normal three-dimensional human posture. There's been a lot of debate in the literature over the last about 10 years about what is the most common source tissue of pain for low back and neck pain. Is it the discs? Is it muscle? Is it fascia? Is it the joints themselves? It almost seems like a moot point to try to wrestle over whether it is a problem in any one of these particular tissues. If you can imagine this, if someone had postural distortion and they had, for instance, a high shoulder or they had head tilt, everything on that right side is being compressed. The muscles, the tendons, the ligaments, the fascia, the joint, the discs are all being compressed, and they're going to undergo probably degenerative changes. Everything on the opposite side, which is being lengthened or eccentrically contracted, is going to break down in a different way and probably harbor pain more commonly on that side. If I can right or correct the person's posture, what's going to happen is the vascular pool improves, the altered neurology improves, disturbances to the disc, all that is taken out of the system, and the person's problem should correct itself. So what I'm more concerned with, rather than treating a specific disc problem or a facet problem or a muscle problem, in treating human posture. Now, sometimes people will split hairs and go, should we be trying to correct function or structure? Bear in mind, when we're looking for restrictions in the way the soft tissue or the joints of the body move, if we correct structure, we have to correct function as well. So as we improve structure, we'll certainly be improving human function. Dr. Hans Selye, the Nobel Prize laureate, made a really phenomenal comment back in 1985 in a textbook that he wrote the introduction for. In that book, he said that the beginning of the disease process is altered human posture. When I first heard that, I was real excited dealing in this work. It was from a credible source such as Dr. Selye. It really helped support what we're trying to accomplish, but at the same time it seemed a little extreme until he explained what he was talking about. If you can follow me here, if we had a person with a high shoulder, again, on the right side, you can't simply have a high shoulder without it causing compression and agitation, irritation to the sensory receptors in those tissues. Now, as chiropractors or body workers, there's two types of sensory receptors we're principally involved with: proprioceptors and nociceptors. Now, the proprioceptors, as you probably recall, deal with muscle motion and position in space, whereas the nociceptors deal with whether those tissues can cause pain or not, so it's associated with pain. If we had a car that drove 120 miles an hour, we're getting to wherever we're going very fast. If we had a car going a half a mile an hour, we're not going to get anywhere. The same proportionality of speed exists between the proprioceptors and the nociceptors, the only difference being the unit of measurement now is meters per second. The proprioceptors are very fast, and they travel on the average at a rate of 120 meters per second. Whereas nociceptors are quite slow, and they travel on average at about a half a meter per second. If I have this high shoulder problem, oftentimes the patient's not aware they have the problem. We may notify them that they, Joe, you have a high shoulder, I can help you with that as a chiropractor. And the patient, because they don't feel pain, may not be so concerned about getting care. The only problem is, the reason they're not feeling pain is because the faster traveling proprioceptors, which have nothing to do with the transmission of pain, at least in terms of causing it, they're beating by a long shot the nociceptive information into the spinal cord. So what now happens is the person may perceive a little stress or stiffness in the area, if they perceive anything at all, and the person doesn't notice that they have this postural alteration. So what's the big deal? The big deal is this. Hans Selye in that paper said that the first efferent response to such deformation of muscle tissue or postural alteration is sympathetic disturbance. In essence, when we start getting an increased rate of firing due to agitated proprioceptors and nociceptors into the spinal cord, the cord's going to perceive it as a threat. And whenever the human organism is threatened, it goes into a flight or fight mechanism. The first thing that happens when our sympathetic nervous system is disturbed is that we get hypoxia. We get vasoconstriction of blood vessels and hypoxia. And as Selye said, we then get hypoxic changes in every segmentally related organ, muscle, gland, and involved skin. That's significant, and as you can probably tell, that would begin a disease process in a person. So we're definitely concerned with correcting human posture for that reason as well. We're genetically programmed to have good posture. Dr. Ida Rolf, the founder of structural integration, from whom this work, at least indirectly, is derived, used to say over and over again that gravity is the true therapist if we're functioning against gravity properly. We have nerve tracts in our body, ascending spinal tracts and descending spinal tracts, whose whole purpose is to assure that we have normal posture, normal structure. The problem is this: if at any point in our life we undergo trauma that would somehow inhibit the amount of these sensory receptors firing into the brain, it's going to alter the way our posture exists in our body. Now, what are some of those traumas? Probably the first one would be the birth process. Not only macro-traumatic events that would follow, but also accumulated microtrauma, repetitive overuse syndromes, and definitely just how we use our body over a long period of time at work and at play. If that's the case, if we're not getting enough stimulation of mechanoreceptors, which are specialized proprioceptors, due to motion, due to quantity and quality of motion, what's going to now happen is we're not getting enough afferent or sensory input into the cerebellum, the part of the brain that controls posture. And when that occurs, the descending spinal pathways now malfunction. Those descending spinal pathways, two of them specifically, control human posture. There's one I want to mention. One's called the reticulospinal pathway. It may not be important if you recall the name of it, but what is important is that the sole function of the reticulospinal pathway, a descending spinal pathway, when it's functioning properly, is to assure that muscles in the front of the body above the 6th thoracic vertebra and muscles below the 6th thoracic vertebra in the back of the body, if they're functioning properly, they will have normal tonus. They will not become hypertonic. As soon as we have alterations in the way we move, specifically meaning diminishment of normal motion due to joint fixation, subluxation, fascial restriction, scar tissue, muscle shortening, when any of that occurs and we don't get enough afferent input or sensory input into the cerebellum, the reticulospinal pathway breaks down in its functioning, and now we have muscles in the front of the body above T6 and the back of the body below T6 shortening. And as you can tell real quickly, the muscles that would shorten would be things like the SCM and the scalenes and the pec muscles. Now we have a head-forward posture or rounded shoulders. So we're going to be searching, as we work with the human body, for where these alterations in neurology and subsequent alterations in posture have occurred, and we're going to correct them. We're also going to guarantee that the person has, once we've worked on them, adequate quantity and quality of motion so that their nervous system and their posture is functioning optimally. Dr. Henri Gillet, one of the pioneers in chiropractic, made the comment that how we age is directly governed by the quantity and quality of our motions. Specifically, he said how we age is governed by our experiences, specifically as to how they relate to quantity and quality of motion. Now, quantity of motion would involve things like exercise. Do we exercise or are we sedentary? Do we stretch? Do we have strengthening exercises, endurance exercises as a part of our lifestyle? But the quality of motion is what we're directly concerned with here when we're practicing chiropractic myofascial release. Does the fascia and the joints and the muscles of the body all have their normal ranges of motion, including what we call joint play or fascial play? Small amounts of motion that must be there for these sensory receptors to function in an undisturbed state. We're going to be palpating for scar tissue in the body. Scar tissue, all experts in pain agree, is the most common cause of pain in the human body. There was a study done at the UCLA Med School which showed that when they took pain populations, including people who had organic complaints, visceral complaints, psychogenic pain, and musculoskeletal pain, scar tissue was the leading cause of their pain. Scar tissue has three unique characteristics that we need to understand before we begin this work. In essence, they're weaker fibers, they're less elastic fibers, and they are more sensitive to pain. The reason they're weaker is because as type 1 collagen, the normal collagen fibers we have in healthy tissues, as they become altered in structure and function, they go from having a nice linear orientation to what we might call a spider web or gauze configuration. When that occurs, their diameter shrinks, and because of that, they're weaker. Because they're weaker, the good news is we can get in there and do fascial release and break the unhealthy or the sick type 3 collagen fibers up without risking damage to the healthy tissues around it. As chiropractors, when we adjust the spine and use the bone as a lever, we're breaking up intra-articular or periarticular scar tissue without damaging fibers around it that are healthy. The bad news is that a lot of people don't seek care, and as they perform activities of daily living, they continue to tear through weaker scar tissue, and the problem metastasizes or spreads through the body. And as it does so, so does its neurological ramifications. The second aspect of scar tissue is that it's less elastic. It's less elastic because of this altered configuration of the fibers. When they now try to move, if this was in my deltoid muscle and I'm trying to move my shoulder in this fashion, instead of the fibers gliding independent of one another, they're tugging and creating friction at the points at which they tug against. The problem with that is that a substance called hyaluronic acid spills from the fibers, and when that occurs, since the function of hyaluronic acid is to draw fluids into an area, it draws waste products along with interstitial fluid, and it congeals and forms what Dr. Rolfe used to refer to as collagen glue. And now we have fibers basically glued against each other. Problem is this: if it's around the joint, it's going to inhibit joint motion. If it's in the fascial planes, it's going to inhibit the firing of mechanoreceptors within the fascia. Also, there's a book published by Kellgren called Management of Common Musculoskeletal Problems, in which he states, and it's a very important statement, that if we exercise a joint if we exercise muscles, that span a dysfunctional joint, it's going to cause joint degeneration. And it usually does so in about 5 years, quite quickly. So if our patients have fascial restrictions, if they have muscle problems, such as we're describing, if they're exercising thinking they can correct the problem, as long as we don't treat the actual source of the altered biomechanics, they're going to actually contribute to degeneration and further progression of their problems. Lastly, these fibers are more subject to pain. The reason being, when we have damage to a muscle or to fascia, when it heals, and it heals with weaker type 3 collagen formation, because it's less elastic, the neurofibrils that have been damaged in that event try to reinnervate the area. When they do so, they're meeting the increased resistance of the less elastic fibers, so they don't quite make it in there. But they'll sprout new endings, and they'll sprout more endings, and even more, until eventually we have a superabundance of nociceptors in the scar tissue, all of which, according to Rene Callier at the University of California in San Francisco, are about 1,000 times more sensitive than they once were to pressure, barometric pressure changes, weather changes, as well as pain and chemical waste products in the body. This is why people hurt more who have myofascial problems. What I want to go through now, before we get into the technique, are a few very simple and brief principles that will help you to learn this technique very easily. Some people have the misconception that this work is very difficult to learn. It's not. It's actually quite easy if you learn the principles, and they're few and simple. What I'm going to be doing is teaching you how to work with the patient with their myofascial tissues as they're in motion. We're not going to have the patient laying there passively. If they're passive, as we press into their tissues, we're going to be basically stimulating nociceptors, and it's going to irritate the patient, or it could irritate the patient, and make the work a lot more painful than it has to be. As soon as I have a patient in motion while I'm working on them, if you recall about the information I just gave you about proprioceptors and nociceptors, the proprioceptive information that's now being elicited by the patient's motion will override the nociceptive information, and it will inhibit quite a lot of the pain the patient would otherwise feel. There still may be a burning sensation or some discomfort, especially with more sensitive tissues and areas of the body, but for the most part, this will keep the pain down. The other principle is that the person will always, with no exception, move their body from a shortened to a lengthened position. For example, if I'm working on my wrist flexors, they won't go like this. They'll go from a shortened position of wrist flexion, and then slowly, at the rate of about 1 inch per second, go into wrist extension. Now, when the patient does that, if they had scar tissue in the flexor retinaculum area, for example, as they extend or take the wrist from a shortened to a lengthened position, what will happen is the muscle and the scar tissue wants to travel S to I, superior to inferior. If I place a thumb contact or a knuckle contact distal to that lesion, the scar tissue now has to meet with the resistance of my thumb, and we begin very safely to break up the scar tissue. And then if we give exercises, stretching exercises, to the patient afterwards, the patient ends up with a much healthier nervous system and also myofascial system. The last principle is the principle of fascial drag. Not only do joints have ranges of motion and muscles, but so does fascia. Now fascia, if you're not familiar with it, is the uncooked, shiny material that you see in meat before you prepare it. It has a very high tensile strength in the human body. It's very strong. It has a tensile strength approximately at 2,000 pounds per square inch. Incidentally, that's a tensile strength of a steel-belted radial tire. Now, fascia covers every tissue in the human body, and it certainly covers muscles. If you can picture my hand here being a muscle and the fascia sitting on top of it, what travels in between the interface of the muscle and the fascia would be our lymph vessels, our vascular structures, and our neurological structures. If for some reason muscle changes its shape, if we get a high shoulder, if we get a head-forward posture, if that happens, the fascia must conform to the new shape of the muscle, and it does so by entrapping or compressing the neurological tissues, the vascular tissues, and the lymphatic structures, and it's going to begin to wreak havoc in the human body. Fascia also is the only physiological continuum in the body. It runs from the top of the head to the bottom of our feet in longitudinal sheets, with a few exceptions. There are some transverse planes of fascia, but for the most part it's running superior to inferior, and it really invests every single tissue in the human body. Because of that, we may have had a person who sprained an ankle years ago, and now the force will be transmitted as far away as the shoulder. We may actually pick up problems in the shoulder. The way we'll do that will be to feel through the skin, pressing through the subcutaneous tissues and seeing if there's normal glide, about a quarter to a half of an inch of motion in specific ranges of motion that I'll teach you later. And if it's restricted, we'll position our thumb or our knuckles or our elbows, whatever we happen to be using, in an appropriate place, have the patient move from a short to a lengthened position, and we'll begin to correct not only the function of these tissues, but definitely their structure as well. There are some contraindications to this technique. The only indication really is altered posture. Understanding that if we have altered posture, it's probably going to lead to pain on one side and probably degenerative conditions on the other side. Now, I'm interested in treating pain. I have a high bias for getting a patient out of pain as soon as possible, because pain is going to cause sympathetic disturbance. It's going to really waste away the nervous system in a very real sense. And I'll teach you ways of using these techniques in an isolated fashion, or taking each technique as an individual entity for the correction of pain. For instance, if I had a patient with an internally rotated shoulder, while I'm definitely interested in treating, among other muscles, the subscapularis, because it's an internal rotator. If I had a patient who had popping and clicking in the shoulder, and they had superior shoulder pain as their main complaint, I would also perhaps take the subscapularis out of its normal routine or sequence and use it on the patient to help them with their pain and with the symptoms they have in the shoulder. What I'm going to do now is discuss a few contraindications, and then we'll bring our model in and we'll begin to go to work. The contraindications are important to understand because this work is deep work. It's superficial and it's deep. We're going to be working some tissues that are superficial, and we're also going to be getting quite deep in other areas. We're going to go anterior to the trachea. We'll be going deep in the abdominal cavity. We'll be going deep into the popliteal fossa. If we don't understand the contraindications, we might create problems. The contraindications are as follows. The first big one would be the area of hemorrhaging. What I'm referring to here is if a patient's a hemophiliac, or if they're in the late stage of diabetes where they have vascular compromise and weakened vascular structures, I don't want to do fascial release on them. There are other lighter, gentler techniques we could pursue. If a person had an infectious process going on in the area that we want to treat, or acute inflammation, if they're acutely injured, we bypass this technique until the inflammation or the infection resolves. If they had malignancy, we would avoid doing myofascial release in that area. There are a couple of vascular problems specific to the legs when we do deep leg work that we need to be aware of. In the popliteal fossa, or really anywhere in the body, if we find varicosities or spider web varicosities in the legs or in the arms, we want to avoid doing deep fascial release over it. If we had, for instance, thrombophlebitis in the calf muscles, we're not going to, or in the deep veins in the calf muscles, we'll avoid doing fascial release there as well. Four other situations. If a person had post-polio syndrome, or if they had fibromyalgia, widespread stiffness and pain, we would avoid doing myofascial release temporarily. Now ultimately, especially with fibromyalgia, understanding the negative impact that postural distortion has on this condition, I want to correct posture. And since this is the best technique I know of to correct posture, I want to use this technique. So I might put the patient on a trial of 3 to 10 treatments using something less invasive. Spray and stretch technique, counter strain, microcurrent, ultrasound, there are other methods I can use until the patient's body begins to come around, and then I can go deeper with the fascial release techniques. If I had a patient who's on a long water fast, 3 days or more, avoid doing fascial release for a few days after their breaking of the fast, and obviously during it, because water fasts will actually, for a moment, cause some weakening of muscles and ligaments, and we don't want to damage them, of course. Also, if a person was on anticoagulant therapy for similar reasons, we would avoid doing fascial release. So what I want to do now is bring our model over, and I'm going to teach you how to do a postural analysis step by step, and then how to begin, in this case, treating the first part of the body we're concerned with, namely the pelvis. We begin the treatment of our patient by doing a detailed assessment of their posture. From what we learn about the postural examination, we can then surmise what muscles and what fascia may be involved in causing the patient's problems. In order for a postural analysis to be accurate, though, the patient's legs must be level. If a person had a leg length deficiency of an anatomical nature that wasn't being corrected, then everything I'm looking at really is skewed. I'm not getting accurate information. A large percentage of the population, believe it or not, has a clinically significant anatomical leg length deficiency. There were 3 papers published in 1994 in Spine magazine indicating that 70% approximately of the population has a clinically significant anatomically short leg. And by clinically significant, they meant a minimum of 3 millimeter discrepancy. An interesting study was done where they took patients who had normal leg lengths. They then put in a 3 millimeter heel lift and had them exercise on a treadmill, and found that the 3 millimeter heel lift actually increased whole body energy expenditure by 30%, which is really a substantial extra load on the way the body has to function. So I'm going to start with analyzing the leg lengths. I could do an x-ray analysis, Chamberlain's analysis from the hips down. That's obviously the superior way of doing it. There are a lot of other tests that really, in my opinion, aren't very accurate compared to what we're going to do now. There's been studies on this system of analysis showing that it has a 95% correlation with x-ray findings. So what I'll do now is I'll go down to our model's feet, and I'm going to check to see if there is a short leg or not. And when I check Claudette's feet, specifically the medial malleoli, the inferiormost aspect, I find a really small discrepancy, probably not even clinically significant. However, there is a slight discrepancy, a shortness on the left side. If I were to draw a line under the malleoli, I would have an oblique line in this fashion. What I want to then measure would be the length anatomically of the tibia, the fibula, and the femur. The way I'll measure the tibia will be I'll come up off of the patella superiorly, and I'll push down on the suprapatellar margin. I should still see a corresponding or a similar oblique line. In other words, I should not see that the legs have leveled out. If I had a half-inch discrepancy here and they were level here, then I would know that there was an anatomical discrepancy at the level of the tibia. But when I check Claudette's patellas, I'm finding that we're getting the same discrepancy that we had at the level of the malleoli. So far everything's fine and indicating a functional lesion, which is easily corrected by working on the pelvis. I then find the fibular heads. I go above them and press down, and I'm looking right over my contacts, and I'm finding again another oblique line, or again shortening at the level of the fibula. I'll then come up and I'm going to check the femur heads, or I'm sorry, the greater trochanters, and I'm going to go above them and press down, and I'm looking for a discrepancy. I'm still finding the same amount. So I've had an oblique line under the medial malleoli, head of the fibula, the tibia, and the femur, which indicates that what we have actually is not an anatomical discrepancy, but a functional discrepancy, meaning that we have a need not to put a heel lift in at this point, but simply to go on to our analysis of the pelvis and treat the pelvis. For instance, if she had, though, an anatomical discrepancy, before I stood her up and began any more postural exams on her, I'd put a 3/4 the amount of the discrepancy as a heel lift in her shoe, let her wear a flat-footed shoe, non-heel shoe, and do my analysis. But she'll be a bare feet now, and we'll go ahead with our analysis. We're going to now begin treating our patient who had a high left denominate. What we're going to be treating will be the quadratus lumborum and the erector muscle lying over it, the oblique muscles, both posterior and anterior, the glute minimus and medius, and then also the psoas muscles. These are all muscles capable of causing innominate elevation. It's important to actually visualize in action the principle of fascial drag. As I'm palpating, and most of the time, with a few exceptions, which we'll point out, we're palpating towards the heart. As I compress through the subcutaneous tissues and then slide upward, you can see there's substantially good motion there. There's no restriction. As I go higher, do the same thing, there's good motion. If I come over here to the obliques, which is customarily a problem for many people, as I press lateral to medial, move upward, there's almost no motion. So that's fascial drag, and we're going to try to elongate that area. We're going to start first with, like as I said, the erector muscles and the quadratus lumborum. We want the patient's upper leg straight, bringing this muscle into a shortened position. I'm going to feel for fascial restriction if I find any. Now, it really doesn't appear to be very much. As I move a little lateral on the erector muscle, about an inch, I do find some right here. Whenever you're doing fascial release work, you want to have a covered thumb or a contact. You want to have as much authority over the muscle as possible so you're not actually causing, you're not losing your contact on the muscle. So I'll have a contact here, a second contact, being careful to press lateral to medial to keep the patient positioned on the table. And I'll then ask the patient slowly to bring the leg up to the opposite shoulder. They're rated about an inch per second. A little faster than that. You want to be angling in, as the doctor, at a 45-degree angle into the tissues. As you notice, I'm not moving my hands at all. She's doing all the motion. As her leg comes up to her opposite shoulder, the muscle is going to move down against my thumb, okay? And relax. Okay. And we would do that actually probably 3 to 5 passes per restricted point. That's the first part of the quad lumborum routine. I'm also going to try to work underneath the 12th rib, which should be about 2 inches above the iliac crest in most patients. Here on Claudette, it's about maybe a half of an inch at the most. So we're going to get under the 12th rib and see if the fascia can glide upward, which you can't do right there. So I take a covered thumb contact, and I'm going to ask her now, faster than before, bring her knee to your opposite shoulder, better speed, yeah. And she's going to bring her knee to up even higher, and then back down. And we would do that several times. After I've completely worked underneath the 12th rib, I'm going to then work on top of the iliac crest. And here is an exception. I'm now palpating down to see if the fascia moves inferiorly over the crest. And actually it does, except right there. I'll take a knuckle contact as I'm pressing with an open hand so I don't get too heavy-handed downward. The patient now is going to move her leg up towards her opposite shoulder. The sensation for the patient usually is characteristically a burning sensation, and for the doctor, it'll often feel like a stretching of saltwater taffy as the fascia begins to release. Lastly, for the quadratus lumborum, I'll displace down towards the floor the erector muscles and try to get in front of them as I work more specifically on the quad lumborum muscle, the lateral aspect of it. Now right here, it feels quite restricted, and right there. So I'll go beneath that lesion, cover my thumb, and then I'm going to ask the patient to bring their knee up to their shoulder again. Now remember, we're doing this approximately 3 to 5 times per point that we find to be restricted before we move on, and then back down. When we work the oblique muscles, there's 2 portions to the muscles. There's a posterior and an anterior portion. If you just can picture a mid-axillary line extending down to the crest, if the muscle we're working on is behind the crest, we're going to go from the straight leg to the opposite shoulder position. If it's anterior to that line, we're going to have the patient start with their leg to the opposite shoulder, bringing it down into a straight leg position. As I mentioned earlier, this is an area of frequent problems with people, primarily because of how often we sit and the fact that we don't diaphragmatically breathe. We have a restriction there, 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 a little better there, but still restricted, there. Quite a bit of this area is restricted, so what I'll do when I have a large area of restriction is use a larger contact instead of a thumb. So I'll use my metacarpal phalangeal area. I could even use an elbow, the portion of my elbow distal to the olecranon process. So I press lateral to medial and inferior to superior underneath the inferiormost piece of scar tissue as the patient lifts their leg to the opposite shoulder. Okay, let's go ahead and do that again. Just to illustrate that we want to do this 3 to 5 times per point. And one more time. Now, usually after I do it that number of times, I'll check and make sure that I've obtained a release, which we have done there. You know, moves much better. Now, when I get to the anterior portion, the patient's going to start with their knee to the opposite shoulder, and I'll make a contact underneath the bottommost lesion, double my contact with my other hand, and I'll ask her to straighten her leg out. She's going to bring her leg down to the straight leg position, and a little bit behind the bottom leg, and that's the, okay, and we would do that several times. You want to treat the obliques as comprehensively as possible. There's two other muscles we want to work on. We're going to work on the glute medius muscle and also glute minimus. Glute maximus is rarely a problem. Even though it's the primary hip extensor, you have to really utilize the glute max in extreme positions to cause it to shorten. Glute minimus and medius will be done exactly the way we did the quadratus lumborum. For glute minimus, I'll find the iliac crest and palpate down to the greater trochanter. Actually, I'll palpate inferior to superior. And if I find a restriction, which thus far I haven't, okay, right along the iliac crest I found some. If I find a restriction, I'm going to use an elbow contact because I found a restriction now that's about 5 inches long. It's restricted here and here, here, quite a bit of restriction. So I'll take in forearm contact underneath the lesion. I press up towards her head and she brings her knee to the opposite shoulder. Now if you care, you can work skin on skin. You can use a lubricant to make this more comfortable for the patient. You can also work through clothes and relax. And we've had the patient do that several times at that level, and then recheck and make sure that it's released. Actually, that one time caused a really significant amount of release. Lastly, for glute medius, we got most of glute medius, the superior portion, with the glute minimus technique, but we also want to work behind the femur head. So I find the femur head and the greater trochanter specifically, and press I to S, feeling for restriction. There's a little bit of restriction right here. I'll use a fist contact. I'll push I to S, and also P to A into the posterior aspect of the femur head and the greater trochanter, and I'll have the patient bring their knee to their opposite shoulder. We'll do that again. This time I'm going to use an even stronger contact. It's important that the person doesn't push you off the contact. Go ahead, again. Just like that. Okay. Next muscle we'll do with the patient lying in a supine position will be the psoas muscle. We'll complete our treatment of the hyonomina by working on the psoas muscle. We'll start by bending the patient's leg in order to relax the abdominal muscles. We'll palpate the ascius and the umbilicus. We're going to bisect the line that these 2 points make. And with a double-handed contact, I'm going to torque in such a way as to displace the mesenteric tissue so we're not actually pressing on it. I'll have the patient breathe in. And as the patient breathes out, I'm going to torque. And it's necessary in the female that the torque be applied towards the pubes using the inferior knife edge of our hand as our landmark. Take a deep breath in again, and then breathe out. The reason why we must torque in this direction on the females, this is the direction the oviducts run in. If we were to go opposite that, we could actually disrupt their fibers. Breathe in again, and cause painful ovulation. Okay, once we've gone in as deep as we can and we're on the psoas muscle, we feel for restriction. If we feel restriction, rather than just using finger contacts, we'll take the knuckles of our superior hand just to give us a little added force so the patient doesn't knock us off the contact. And the patient will be instructed 3 times to slide their foot down the table, and at the very end to externally rotate the leg. So just turn the foot out towards me. Good, that's it again. What I got? I'm going to slide down the table. I'm pressing lateral to medial, inferior to superior, anterior to posterior. That's good. The leg will come back up. We'll then move on to the iliacus portion of the iliopsoas. With my superior hand, I'll take my thumb. I'll go 1 inch medial to the ascius. And as the patient breathes out 3 times, I'll go a little deeper each time. Take a deep breath in. Breathe out. Deep breath in again. And breathe out. I'm about already as deep as I want to go. At that point, I take the piezoform of my inferior hand and I compress medial to lateral my thumb against the iliac fossa so I can actually trap the muscle. And I feel for any restriction headward, and there's some right there. I go a little beneath the restriction, and I ask the patient once more to slide their foot down the table, and at the very end of that motion to externally rotate or turn the foot out towards me. And again. Now in actuality, we'd be doing this 3 to 5 times per point. Okay. She'll come in the same position, and the last thing we'll do is treat the insertion of the psoas The insertion of the size is real important. A lot of times, from a symptomatic perspective, it's involved with deep hip pain. And if the patient had deep hip pain, I could use this as an isolated technique. I can't get to the lesser trochanter in this position. If I have her externally rotate her leg against my resistance, the muscles are now relaxed, plus the lesser trochanter has been brought into an accessible position. I find the ASIS, and I ask the patient with her opposite hand to point to her pubic bone. Then I bisect in my, just visually, go ahead, keep it there. I bisect the inguinal ligament, you can let go now, and then I drop 1 inch inferior, and I palpate for a tendon that feels the size, oh, it's probably about a half of an inch in diameter. And when I find the size tendon, I move upward, I to S, feeling for restriction. There's quite a lot of restriction here. I'll take a pisiform contact on top of the thumb, and then I'll ask the patient simply to slide the foot down the table. She doesn't have to focus on turning the foot out because it already is. Let's do that again. Start out in external rotation. Good. And again. If this is real sensitive to your patient, stay on the contact but use less force, or you could use a lubricant. There are several reasons why we can do these muscles we just discussed from a symptomatic perspective. The psoas muscle oftentimes is involved with vertical low back pain, menstrual cramps, disc lesions. It sometimes is active in symptomatic spondylolisthesis. Quadratus lumborum is oftentimes involved with horizontal low back pain. So in addition to treating these muscles for the postural reasons we've discussed, there are those symptomatic applications as well. Next, we're going to treat the low innominate side, which in her case is the right side. The reason we're choosing this side is because when she went from a standing to a sitting posture, the high innominate remained high upon sitting. So we knew the main lesions causing the hip dysfunction were up in the QL and the psoas and the obliques on the left side. Even so, we still want to treat the muscles on the right side because they're probably involved also with, to some extent, causing a low right innominate. Now, if our patient, when they went from a standing to a sitting posture, if the lesion corrected, in other words, their innominates became level sitting, we would start with the following leg work and buttock work, and then afterwards we would go up and treat the QL, the obliques, and the psoas muscle. The muscles we're going to do now in order would be the glute medius and minimus, which we've already shown previously, and then we'll move on to the quadriceps, the entire quadricep group, which can all, because of its upper attachment, pull the innominate down. I'm going to start at vastus lateralis, the lateral aspect of the superior patella, and I'm going to work up into the AIIS area. I'll work the rectus femoris and the vastus medialis as well. And I'm going to be feeling for restriction. Typically where you find most of your restrictions are where fascia and muscle attaches to bony prominences. So down here I find some. As I go up a little higher, it feels pretty good. And it gets a little tight up here. So I have a couple lesions to treat. And I'm going to have the patient go from the shortened position, which in the lower part of this two-joint muscle happens to be knee flexion, and then I'll have her extend. And I'm pushing I to S as she does that. Now obviously if I'm pushing downward and she's moving downward, it's real easy to cause the leg to flop down towards the table. So I'm taking my fingers on the opposite side and pulling up a little bit at the same time to prevent that from happening. And again. And one more time. Okay, then I check and see if that's corrected, and we got some nice motion there. In the superior part of this two-joint muscle, I'm going to have her go from hip flexion to hip extension. I'll use a knuckle contact backed by another hand as she now tries to lengthen the leg and the muscle by going into hip extension. So she'll slide her foot down the table. Just like that. We would do that several times. We would do the same thing on any portion of the rectus femoris that was dysfunctional and the vastus medialis. When we're done that, and only when we've done that, we'll take the now loosened muscles, especially the rectus femoris, displace it immediately and check the vastus intermedius underneath, which is a muscle that's oftentimes responsible for causing a lot of knee dysfunction and pain. It's really a problem right here. It feels like a brick wall. When I go a little higher, it still feels like a problem. When I go higher, now it begins to ease up. And I would check this all the way to its upper attachment by the hip. Since this is towards the knee, I'll have her go from slight knee flexion to extension. And again, a lot of dysfunction here. We would do 3 to 5 passes and always come back and check to make sure afterwards our work had been successful. feels like an old problem right there. We would also take the rectus femoris, displace it laterally, and work on the medial aspect of the vastus intermedius in the same fashion. The next thing I would do is I'd work the lateral aspect of this group of muscles, the tensor fasciolata, and I'm going to work from actually slightly below the knee, because this portion of the muscle and its fascia serves as an accessory lateral collateral ligament. So I'm going to work below the knee up into both the greater trochanter and also the ASIS where it attaches anteriorly. I'll have an open fist contact, and I'm going to take the patient from slight abduction. I'm going to stabilize her foot so it doesn't flare out towards me, and I'm going to bring her leg into adduction. I'll do that several times. As I go higher, the work doesn't change, and if I get by the greater trochanter, which is where we oftentimes find a lot of problems, I'm going to be going from same position, abduction to adduction. And I can do the same thing, maybe with a thumb contact to get more specific on the ASIS, or I can use knuckles, the actual tips of my knuckles, but lightly, as I bring her from abduction of the hip to adduction. Then I'll move on to the biceps femoris, which of course runs from the lateral aspect of the knee to the lateral aspect of the ischial tuberosity. To treat the origin of it, which oftentimes is involved in hamstring pulls and oftentimes is involved in sacroiliac pain, I'm going to find the ischial tuberosity. I'll go superior to it, and I'm pushing towards the heart again, feeling for any restriction in motion. Now it feels pretty good here, except right there it feels stuck, so I'll go beneath the lesion actually. I'll have an open fist contact pressing I to S and P to A, and I'll bring the patient, even though it's not an extended position, compared to how I'm going to end up in flexion, it's relative extension. So I'll start here with about 90 degrees of flexion. Hands above your head, please. And as I push up, I'm going to go into quite a bit of flexion and try to break up the scar tissue. And I'll do it several times, 2 to 3 times. Okay. Then I'll ask the patient to turn face down in a prone position. And I'm going to work the lower portion of the biceps femoris. I'll go from the lateral aspect of the knee, actually distal to the popliteal fossa, and I'll work about halfway up the knee in that fashion. Now, in this area, it's quite common to find a lot of lesions, which we do find. I'll have the patient go from a flexed knee position as I do a covered thumb contact and have her go into extension. We'll do that again. Okay. One more time. Then I'll continue working superiorly. That spot released, but right above it, there's more we want to treat. We could use knuckles if we wanted to. Just like that. Now she's doing this motion. I'm just kind of preventing her from going too fast. And then a third time. And that would complete the muscle work we need to do and the fascial work we need to do to correct the low innominate. From a symptomatic perspective, though, there are a few reasons why we would want to treat these muscles besides the postural reasons we've just discussed. The quadriceps are oftentimes involved with knee pain of varying degrees, especially deep knee pain, which is associated usually with the vastus intermedialis. Tensor fasciolata is involved with snapping hip syndrome, trochanteric bursitis. It's oftentimes involved with lateral knee pain. The biceps femoris usually is involved with sacroiliac joint pain and also with ischial pain, and could also be involved with ischial bursitis. The next area of dysfunction that we'll treat will be what we'll refer to as torsioning of the pelvis. If you can visualize a straight line or an axis of rotation going up the center of my body, much like the spine, as I rotate around it in this fashion, that is called torsioning. If I have torsioning in this fashion, where the left side is anterior, we'll refer to that as left anterior torsioning of the pelvis. The muscles that could possibly be involved would be on the same side of anterior torsioning, the psoas, which can rotate the pelvis internally. And also on the side of posterior rotation, or external rotation, we had the piriformis, the glute minimus, and the medius. Now we've already gone over the treatment protocol for the psoas and the 2 gluteus muscles I just mentioned, so we need now to discuss the treatment for the piriformis muscle. But don't forget that we have to treat ipsilaterally the psoas and contralaterally also the gluteus minimus and medius. The piriformis muscle runs anteriorly to the sacrum and goes out towards the area of the greater trochanter. To find specifically where it emerges from underneath the sacrum, find the apex of the sacrum and the PSIS, and bisect the line that those 2 points make, and then just fire it out, just trace it out towards its attachment on the greater trochanter. Again, we typically find lesions where we find bony attachments of the muscles and fascia, so along the greater trochanter and along actually the entire lateral margin of the sacrum I can expect to find lesions. Even though this is not piriformis proper, it's the fascia that invests it actually spreads inferiorly and superiorly to invest the entire lateral margin of the sacrum. I don't find much here along the greater trochanter, but if I did, I would use an open fist contact, place it lateral to medial, I to S and anterior to posterior, or posterior to anterior rather, and I'm going to passively in this case bring the patient's leg from external rotation to internal rotation in this fashion. I would do it several times. I did find quite a bit of restriction lateral to medial into the lateral margin of the sacrum, actually pretty much the entire lateral margin. So I'll take broad open-fisted contacts and again passively move the patient from external rotation, the motion of the piriformis, to internal rotation. I would do each spot approximately 2 to 3 times, up to 5 times. I'm going to work all the way up to the area by the PSIS, just like this. Problems that the piriformis muscle could cause, the most common one would be posterior thigh pain or sciatica. And it's safe to get on the sciatic nerve if we have to. In this fashion, with the patient in motion, we can break scar tissue up very quickly and help the patient with sciatica by doing the piriformis technique. The next and final part of our treatment of the pelvis will involve what we'll refer to as a rotated pelvis, where the pelvis is rotating along an axis. If you can imagine a javelin going through my hips and coming out in this fashion, rotating either forward or anterior or posterior or backward. The more common lesion will be the anteriorly rotated pelvis, and when it occurs, it's quite significant. The angle we're going to be checking is called the angle of pelvic inclination, and it runs through the ASIS and the PSIS on each side of the pelvis. The angle in a male should be 0 to 5 degrees, and in a female 5 to 10 degrees. If it exceeds that angle, what it does, it will usually create a hyperlordosis in the lumbar spine. It could lead to facet syndrome, posterolateral or posterior disc degeneration, and quite commonly causes a syndrome known as pelvic pain and organic dysfunction syndrome. This has been written about in the literature quite a bit in the last 5 or 6 years. What happens during pelvic pain and organic dysfunction syndrome is that during the increased rotation anteriorward of the innominate, we have a tethering or a stretching of the lower sacral nerve roots. When this occurs, it causes an ischemic or hypoxic condition in the pelvic cavity, leading to pelvic pain of all sorts, but also pelvic organic dysfunction, ranging from dysmenorrhea, amenorrhea, menstrual cramps, impotence, painful intercourse, inability to orgasm, quite a few significant problems, along with a lot of itises, prostatitis, urethritis, epididymitis, conditions such as that. So what I'll do now, we'll bring our model on, we'll do an analysis of the pelvis, and then we'll go ahead and teach you how to treat anterior and posteriorly rotated pelvis. Okay. What I'll do is I'll have the patient stand. One more. Okay. I want to be facing her in the coronal plane. I'm going to take a finger underneath the ASIS and the finger underneath the PSIS. I don't want to merely find the anterior-most projection of the ASIS and place the finger there. This landmark varies on everyone, and I may be, in that case, here today, here the next day, here the next treatment. I'm going to get under the ledge and pull up, underneath the PSIS ledge and pull up. And if you look, eyeballing that, it looks like an angle of around 10 degrees, which is normal for a female. By the way, there has been research done on this showing that this visual measurement is 98% accurate against pelvic inclinometer readings and 95% accurate against x-ray findings. I'll have the patient then turn the neck the other way around, 180 degrees. I'll place a finger under the ASIS and a finger under the PSIS, and now you see the angle is quite large. It's about 20 to 25 degrees, which is significant and could cause a lot of problems on this left side. So So what I'll now do is begin the treatment of this by having the patient lie in a supine position on your back. It's a 6-part procedure. Now, the only indication for doing this is that the pelvic angle exceeds, in her case, 10 degrees. There are some contraindications, though. If she had hypermobility of the SI joints, or she was in her first trimester of pregnancy, we would not, under any circumstances, do this routine. If she had SI joint hypermobility, I would probably trochanteric belt her for about 4 to 6 weeks while she's undergoing some type of exercising using an ankle board, wobble shoe, something that's going to strengthen the ligaments in the ankles, the knees, and especially the pelvis. I need your arms above your head. The legs will be bent. The first part's called pelvic rocking, and it involves taking a thenar eminence contact inferior to the ASIS as I bilaterally move the sacroiliac joint in an A to P, P to A fashion. Now, as you notice, I'm alternating my motion. If there's any pain there, I'll take note of it and probably do a little trigger point work there at a later time. The next part's called lateral presses, and there is an additional contraindication for this, and that would be if she had any osteoporosis in the pelvis. I'll take my thenar eminence contact again, and I'm going to press lateral to medial, just like this, lateral to medial, for 15 seconds, using about 25 pounds of pressure. I hold it for 10 seconds, and then I release. I do it a second time, and I do it a third time for about 10 seconds each. The third thing will be pelvic shifting, and this is going to be an active exercise the patient will do on the table at this time, but also at home as an exercise. I'll place my hands on the ASISs just to get her started in the motion, and I'll ask the patient to shrug the left hip to the left shoulder as the right hip comes down, then to shrug the right hip to the right shoulder as the left hip comes down, and then to continue doing that. As you notice, with all of these first 3 moves, the knees are together and the legs are bent. That enables the SI joints to decompress. She'll do it a few more times. Now the patient will be told to do this morning and night 20 times on each side. It's a good way of strengthening, stretching the quadratus lumborum muscle, okay? The fourth part is leg traction. What we're going to do, we're going to stimulate proprioceptors in the ankles, which is an area of the body that has been referred to by Vladimir Janda as an area of proprioceptive amplification, meaning if I adjust the ankle, or the wrist for that matter, the other area of the body that serves this function, it fires mechanoreceptors and proprioceptors elsewhere in the body and serves to improve posture. I take a middle finger contact in the mortise joint, I back it up by my other hand, I bring her into 10 degrees of dorsiflexion, internal rotation, and then if the patient will hold onto the side of the table, I will quickly apply a downward pull. By no means is it important to get a cracking sound when we do that. We just want to stimulate very quickly with a fast stretch the proprioceptors in this area. Again, a middle finger contact in the mortise joint, backed up by my second hand, 10 degrees of dorsiflexion, internal rotation, traction downward, and that's a quick pull in that fashion. The fifth part of the technique is called hip rotation. You can do this with a hip prosthesis. You can do this if the patient's scheduled to receive a hip prosthesis. However, if they had osteoporosis of the femoral neck, I would not do this routine. The patient's leg is bent. I bring the patient into full abduction while I have my superior hand above the knee, my inferior hand above the ankle. At this point, I internally rotate the thigh until the knee is locked at 90 degrees of flexion. I'm now going to bring her knee up towards her chin, feeling for any resistance to this stretch. Now right here it's stuck. So what I'll do is I'll ask the patient to push into my hand. They're going to push, in this case she's pushing from her left further to her left against my resistance for about 6 seconds. Then when she relaxes, I continue this arc of motion, which is about 180 degree semicircle, up towards her chin, eventually over to her opposite hip. She's stuck right here. She'll push out again into my hand. So she's pushing in this direction. Okay. And relax. I continue stretching her in this fashion. It's okay if the buttock comes up on the opposite side. Now she's stuck here again. She'll push up one more time. 6 seconds. And then we relax. And we go all the way to the opposite hip where we find one more lesion to be corrected. Push up again. Now she's pushing pretty much up towards the ceiling. Now once we've completed this 180 degrees from the involved hip to the uninvolved hip, in this position, in this location, I externally rotate the thigh. And then I bring her back from the opposite hip towards the chin to the involved hip. If I find any restriction, as I do here, she'll be instructed to pull into my hand for 6 seconds. She relaxes, and I complete the technique. This is always done on both sides, but for time's sake, we'll skip the right side. Now we'll move on to the actual technique that repositions the pelvis. This is called pelvic derotation. I take the involved leg and I place it on my shoulder. I take a fist contact under the ischial tuberosity. Okay, actually what I'll be doing is I'll be making a contact, so you can see it better, like this, underneath the ischial tuberosity and pulling up P to A. So again, I take the involved leg and I place it on my shoulder. My superior hand is underneath the ischial tuberosity. My inferior hand will be behind the hamstring muscle. Okay, get your hands above your head. Now what I'm going to do, I'm going to push I to S on the hamstrings, pull P to A with my contact on the ischial tuberosity. At that time that I'm doing this for 10 seconds, the entire 10 seconds, the patient will very, very slightly push down on my shoulder, which tightens the hamstrings, facilitating this motion into posterior rotation. Not yet. Okay, I wait for the opposite leg to begin to raise, at which point the SI joint is considered taking the tension. Push down now very gently, a little less force. And I derotate her for about 6 seconds. For every 10 degrees that I try to correct, I'll do 1 derotation. So we're going for 15 degrees here, so I'll do 2. I'll do an additional 1. Again, I bring her leg up until I see the opposite leg raise, which it does there. I push down again, and I derotate her. Now, since the right side was normal and within normal limits, I won't do this technique on the right side. Everything is done bilaterally except for the last part, unless both sides need to be treated. If you find that you can't move the pelvis, consider the fact that she may have an SI joint fixation or a pubic symphysis fixation, adjust that and then come back to it. If she had a negative angle, if I checked her angles and she actually had, say, a -2 degree angle, or for a female, actually a 3 degree angle is considered insufficient, I do the first 5 steps exactly the same. And then for part 6, I would have, if it was on the left side, I'd have the patient come to the very edge of the table, so the trochanter is almost a little off the table. I take the involved leg in between my thighs. I take my inferior hand on the opposite ASIS and I distract the leg, and then I just don't merely drop the leg towards the floor. I try to push the superior part and translate it back until I reach the first barrier of resistance, which I feel right there. Then I distract again, and I have the patient push up against my thigh, against my hand rather. So she's pushing in this fashion against my resistance. We're stretching the anterior iliofemoral ligament and the psoas by doing this. Then I bring her down to the next barrier of resistance, distract, and I do this usually 3 times to correct the posteriorly rotated pelvis. That completes our treatment of the pelvis. And from here, we would go on in later sessions and work on the lower legs and the feet.